talk a little bit about what the affiliation of the special interest group is to the APHN and how that might work, from Dr. Ednin Hamza, who is a GP and palliative care specialist in Kuala Lumpur and the chair of the APHN. So it's great to have a primary palliative care enthusiast in that significant role. And thank you so much to him for moving things forward with the APHN board. So we'll hear more later. But we thought it would be good to focus on the issue of the moment, COVID-19. As we know, we were hoping that things may be settling down, but with this new Omicron variant, it looks like things are taking off, certainly in the UK. Obviously that's a concern for around the world as well, as there seems to be some vaccine escape from that. So I think palliative care delivery in COVID isn't going away anytime soon, and so it's great that we can learn from two colleagues and their services today. We have Dr. Sylvia McCarthy and Dr. Ashita Singh from Malaysia and India. So two very different areas, one capital city, the other in a very rural area. And so I'll introduce them in just a minute, just to say that please think of questions to ask. It'll be good to get some discussion going. And so maybe if you think of a question, it's a good thing to write it in the chat, so you don't forget it, and we make sure that it's sort of listed to be asked. And then maybe we'll have some discussion, 15-20 minutes or however long we need at the end, and get some good discussion going so that we can all learn what for us all. I think we're on a very steep learning curve still around palliative care and COVID. So first of all, I'd just like to welcome Dr. Sylvia, who's been a member of this group since the beginning, and is works at Hospice Malaysia in Kuala Lumpur, leading the service there. Is previously a GP from the UK, and it has been running Hospice Malaysia, or working there since 2003. So Sylvia's very kindly agreed to talk to us about their experiences with the COVID-19 pandemic. So over to you, Sylvia. Thank you.
Thank you very much, Dan. And thanks to everyone for joining today. Sorry, just trying to share my screen. Yeah. Okay. Can everyone see that? Great.
Yeah, I think so.
Okay. So obviously we're a very urban practice, and I'm talking largely about the Hospice Malaysia experience. More rural areas, we have less information about how they've fared. So I'm going to talk a little bit about, just give you some background, and then think about how it's affected our patients, but also our services, and what think we've learned from it, and what we think we might carry through to the future. So Kuala Lumpur, capital city of Malaysia, I think it's 7 million at the last count. Am I right? Correct me if I'm wrong. We had about 2,200 referrals this year so far. And so we're quite a big service. And we have 12 nurses and 4 doctors. The nurses at any one time, it's a nurse-led service, and they each cover one area, and they have about 30 to 40 patients under their care. We do quite a lot of education as well. So we're involved in the undergraduate, and during the pandemic, that more or less disappeared. Certainly all face-to-face teaching disappeared. And we also have the palliative care specialist trainees, so people who, in Malaysia, it's a subspecialty of medicine, and they do 6 months community with us. And the family medicine specialists who are trained, like GP training, and also advocacy. So we're fortunate we have a lovely building, but we don't have inpatients. And those are our nurses setting off for the day's visits. So what happened for us was in March 2020 was our first, we called them movement control orders, which is the equivalent of lockdowns. And that the first one was very strict indeed. And in the hospitals, palliative units, care units tended to be closed to make way for admissions. And most palliative care services in the community moved to doing phone calls and WhatsApp video calls and things. Just moving on through the pandemic, through the 2 years, lots of patients initially all patients with COVID and their contacts were admitted to hospital. Obviously that didn't last very long. As numbers grew, that wasn't viable. And what they did was open big quarantine centers where anyone who was a contact or anyone who was a contact was first initially, and then later, again, people who were positive were moved into the quarantine centers. So essentially, as soon as you have a positive PCR test, you have no choice. They will come and pick you up at home and take you where they think you belong. And that obviously affected our patients' choices quite a lot. But it all evolved, and eventually there was a system for caring for patients at home using an app, and you report your symptoms and you're asked to be monitored at home. But if, like me, you're too old, you would be sent off to a hospital facility. And our vaccination program started first quite slowly, just frontliners in February, and it really ramped up in June this year. I just thought I'd share our graphs with you. I'm sure many of you know this website that does all these lovely data things, because it shows the pattern. The beginning was very slow. There was a sort of peak around the end of last year, and then the really difficult bad time was June until, it feels a long time ago now, but it's not really, September. We started kind of opening up again, and we were not allowed to travel across state borders. You needed police passes to travel and so on. And that's just to show you, we've had a large number of deaths, and but our vaccination program has been considered quite effective, and we're now all receiving boosters, and that's been rolled out quite fast. And so the vaccination program coincides with the improvement in situation in the hospital. So for us as an organization, we immediately decided to continue the service and to continue it with physical visits. We see patients really very much at the end of life, and we didn't think you could move all of that into virtual consultations. I'm sure I'm talking to other palliative care people here, so the communication aspect of it, particularly when someone's very ill, not wanting to be dependent on only the carer's assessment of what was going on, needing to do a physical examination. But we did divide our team into two, so that if one team went down, the other could still keep functioning. And we told them we're lucky with our building, we were able to say, you're in this half, you're in the other half, and you can't meet. And in terms of staff needs, so initially they were a bit nervous, but all of them, even though they were worried about their families, were worried about their patients, and they were happy to continue to work. Nobody said that they didn't want to work. We tried to support them by checking in with them, and this is where our physical in-person meetings we felt were very important, because I don't think they would share on a Zoom call. And we'd set up some ways for them to have a space to reflect. And we regularly asked them to tell us what they were scared about. Food was another important bonding thing. People baked. So for patients, they had issues with access to medication. There was no more respite care, and obviously that really affected their goals of care decision-making. They were far more isolated. There were financial constraints because there was loss of income. If they were thinking about inpatient care, it had to go into the private sector sometimes. And in the private sector, obviously, there was the fear of being COVID positive, and immediately that brings you to the point of bankruptcy, I think. And there's just generally less availability of care, not for our patients in the public sector. And there were some changes in the procedures after death. In fact, that almost became more efficient because paramedics were easy to call to the home, because that's the system here, that the paramedics come and certify. But there were requirements to take patients to hospital if they were thought to be possible COVID patients. So these are all things that the patients had to, and families had to kind of negotiate and deal with, and it was definitely stress factors for them. So looking at some of the pictures, I thought it's worth showing. If there were areas where there were a lot of cases, they literally isolated whole blocks of flats behind barbed wire, and you couldn't come in and go out. So there were a lot of constraints. For the second time around that they did that, we got some permission to go into those flats, but initially we couldn't even go in. And these are the kind of roadblocks that were around, and limited, or rather extended our travel time. When there's finally no traffic on the roads, we get roadblocks instead. And these are some of the kind of pictures doing the rounds in the media. And obviously, when you see this kind of thing, and there's a lot going around on WhatsApp, a lot of fear. Our patients do not want to be admitted if they can at all help it. Some of the kind of things were, these are some quotes that were taken very early on, and it's the nurses' reflections of what they've observed at home. So patients refusing to go back to hospital, whereas previously, if someone has spinal cord compression, there's an option to go back and be treated. They definitely weren't going to, because of fear that they couldn't do pleural and ascites tapping in hospital. And they really felt neglected. They felt that the healthcare system wasn't quite there for them, but they were very supportive of our care. So early on, patients and families really stepped up to help us with things like PPE, and to help us with this campaign to let people know we still needed funding. So that sign is just saying thank you very much to us. And you can see one of our doctors doing a ascites tap at home. Of course, there were lots of issues around people being separated from loved ones, and a lot of sadness around that, and sadness that they couldn't hold funerals. And I'm sure that's similar for many of you. Practical challenges, needing permissions to travel just to collect medication, and just the increased costs involved as well. For some people, buying masks was expensive. But there were some positives out of it. So some people, because they could work from home, could spend more quality time with a family member. For the staff, what they felt, that there was a fear of infection. They were very fearful of being the vector that transmits COVID from one patient to another. But some of them also obviously were worried about family members that they stayed with. And initially there were some of them were offering to kind of live on their own and live away from family so that they could continue working. And there's this sense that with all the PPE, it becomes so much more difficult to communicate well and express empathy, and not being able to sit so close to patients or family members, having to ask family members to stay out of the room. So we had a list of screening questions before we did a visit, and we asked them to make sure there was only one carer in the room and that carer was wearing a mask. In practice, I did visits where that really didn't happen. Our team was not really that strict. They're too caring sometimes. And the practical problems for the nurses that just affected how they were working, they really missed eating together. It's a very Malaysian thing. And the social support of friends, roadblocks were a tiresome thing. For the clinical services, so I think for sort of management level policies, as an NGO, we're not that well connected to government. And so we were worried a little bit about being out of the loop. And we had to get permissions to travel and keep on working. The picture you see here is all the letters of permission that I've collected over the last 2 years that allow me to travel during an MCO. So every time there's a change, you have to have another level of permission and negotiation. And unfortunately, we are not asked to give our perspective or our input. We just receive policies coming down. And sometimes we ignore them a little bit. And there's the issue of PPE. That was a worry to start off with, but very, very quickly people stepped up to help us with that. Funding, again, patients and families were very supportive, but there was definitely a worry about funding. There was concern about whether we would be vaccinated with alongside other frontliners, but in fact that did go ahead. And medication was a problem. So in fact, at that point, we were in an advantage point because we can procure our own medication at a time when the hospital said that they were running out of morphine, running out of dexamethasone. We could still procure for our patients. I thought I'd show you a little bit of data. We haven't yet finished 2021, but the numbers in terms of referrals actually haven't changed from 2019 very much. What has changed, and I'm not sure if you can appreciate it, is the length of time under our care. So patients are being referred very late, and that's got worse over these 2 years. So our nurses were looking after a lot of very sick patients, and they had a very short time to care for them. And I think that adds to the burden of care. And the other thing is that the number of patients in 2021, so that's the brighter blue line, who died at home, the percentage went up, which I think just reflects the choices that they were making. Some of the ethical issues, I was just going to tell you a couple of quick stories that I think illustrate some of the problems. On a management level, it sort of around staff needs versus patient needs, balancing that. And also then I think for everyone, it was how do we carry on teaching without endangering patients? So that the first story is just about how easy it is with all these policies and strict SOPs, that it was easy to lose sight of the human stories that maybe didn't have to be so terrible if we just thought about it. And this was a 39-year-old lady with breast cancer. In just before pandemic in October, she had spinal cord compression. And because of her home situation, her husband had to work and they had a young daughter that needed full-time care. She was admitted to a welfare home and the daughter was admitted to an orphanage. And when this MCO came, they couldn't see each other. And they didn't see each other for a whole year until we realized what was going on. And in fact, until the patient had really become quite sad and withdrawn and probably clinically depressed. And it took a sort of careful negotiation of respecting their fears around everyone in the orphanage or everyone in the nursing home catching COVID, and suggesting ways in which safe visiting could happen. And I felt very much like everyone had just lost sight of what went on. And with a bit of conversation, safe visiting was arranged, and it made a huge, huge difference, and it's been able to continue. And I think that's where palliative care has a strong role for keeping an eye on those kind of situations. And the other thing was that the thing I mentioned earlier, if you have a positive COVID test, you lose control of some of your options. And our patients knew this. And this was a gentleman who possibly had COVID and absolutely refused to be tested because of fear of being admitted. And we had to sort of take some time as to what was our role in this, and should we be saying, you know, no, you really need to be tested. We didn't feel anyone else was at risk, and so we supported his decision not to test, but just took appropriate precautions. But those kind of issues arose and were quite difficult at times to negotiate and think what was our role to the patient and to the community. What are the lessons that I think we've learned? One, there's some really good ones around the support that we've received from patients and families. And I think our team worked together really well and really stepped up. In the face, some of them were really challenged by their families as to why they were doing what they were doing. Phases of illness was very useful in helping to prioritize what we were doing. We thought virtual consultations had a limited space, a limited place in what we were doing, possibly some uses. Our pharmacy practices improved just because we had to be more efficient and couldn't do it so much face-to-face. We learned to do some e-learning for our students, and we also did some virtual engagement with carers to get feedback on the service. And we hope that that's something that we'll take into the future. The other things that we want to look for in the future, that there's a real role for palliative care with serious illness conversations and symptom control. I hope in the latter part of the pandemic, other specialties are beginning to see that. But initially, the palliative care was thought to be the ones that could give way to the other specialties. But now that they have lots of people with significant lung damage who need ongoing care, I think they're beginning to see that there's a role, and that there's a role earlier in terms of the serious illness conversations. I think it really shows up that our community services need to be better, not just palliative care, but as a whole. And I'm hoping that that's somewhere where we can engage and advocate for better palliative care services in the community. I hope we've improved our care engagement, and we're looking forward to doing some work on compassionate communities. It will be interesting to see the bereavement outcomes, whether there's a greater burden because of what patients have had to deal with. And that's my presentation. Thank you.
Thank you so much, Sylvia. That was great.
That wasn't too long.
No, not at all. Really interesting, and I'm sure you could have told us a lot more. So,
Yes.
But thank you for giving us a very interesting overview. I think a lot of us will sort of recognise resonances with other places in the world in terms of the sort of things that you've been going through. We'll come to questions after Ashita's talk, I think. So I noticed no one's written anything in the chat. Maybe I should have started and written something, but please do write in the chat. Otherwise, I'm just going to be asking all my questions when we come to the discussion time. And so we'll go on to Ashita. Thank you so much, Ashita, for coming and being part of the group and presenting to us your experience. I've known Ashita for a number of years, and I knew what amazing work she'd been doing in her unit, where they have a community palliative care team. Ashita's a physician, trained in general medicine and infectious diseases, and has worked for many years in rural areas in India, first in northeast India, and then more recently in Maharastra, and has got lots of experience working with very poor remote communities. So thank you so much, Ashita, for joining us, and we really look forward to your talk. Thank you. We can't hear you, Ashita. I don't know if you're...
I'm sorry, I'd forgotten to unmute.
Yeah.
Good afternoon, everyone, and thank you so much, Dan, for this invitation and this opportunity. And I think it's a privilege for me to be a part of this group, and I really look forward to interacting and learning in the coming days. So over the next 10 minutes, I'd just like to share with you briefly the context of our work in palliative care in rural North India. This is both through Emmanuel Hospital Association, which our hospital at Chinchpada is a part of. So Emmanuel Hospital Association is an organization with a focus on North India, and we have about 19 hospitals under Emmanuel Hospital Association. And also in particular at Chinchpada Christian Hospital, where I work. So Emmanuel Hospital Association is a non-government organization with 19 hospitals and 30 community health projects, with a vision of taking quality health care to the underserved rural areas in North India. Home-based palliative care was started in EHA in the year 2010, and there are currently 10 active palliative care units across the organization. So our typical palliative care teams consist of 3 to 4 members, and they are home-based palliative care teams. Most of our teams are nurse or social worker led, with support and supervision by a doctor who's trained in palliative care. These are some images from a recent visit that I had made to 4 of our palliative care units in North India, in Uttar Pradesh. And I was really encouraged and moved to see the excellent work that they are carrying out faithfully in some very, very challenging contexts, as you can see in these pictures. At Chinchpada, we began the palliative care home care program in 2016 and have since cared for about 470 patients with life-limiting illnesses, and currently 75 patients receive home-based care, while the rest have passed on. The COVID-19 pandemic has highlighted many of the pre-existing challenges to flourishing for our people living in this remote rural area, and has also brought new ones, particularly for palliative care delivery. However, I also feel that the human experience of pain, suffering, and grief that was collectively shared by our world during the pandemic has actually affirmed the immense value of palliative care and the holistic relational approach to caring that palliative care embodies. Some of the pre-existing challenges that our communities around Chinchpada face include illiteracy, poverty, dependence on ancient, often harmful indigenous treatments, mistrust of modern medicine that causes needless deaths. And just an example of that is that we still have 2 or 3 patients with severe generalized tetanus admitted to our hospital every year. Poor access to good quality secondary and tertiary level healthcare, lack of access to optimal management of treatable conditions that could lead to death, like cancer, early cancer, tuberculosis, and genetically transmitted diseases that are sort of geographically confined to our tribal areas, like sickle cell disease. All these are very rampant in this tribal region. Challenges from the perspective of the hospital include severe resource limitation, as we serve a population where about 72% of our people live below the poverty line. Difficulty in getting qualified professionals who would be willing to live and work in such places, multitasking by a few available hands, remoteness of our location that often makes availability of supplies and services difficult, and meeting the legal requirements for various hospital licenses. I think another major challenge to working in remote rural areas like these are that there is a pressing need for us as healthcare providers to constantly redefine quality to match the realities of the desperately broken worlds of our patients. And this journey of redefining and finding the new meaning of quality that matches their world is crucial, and it must be learned in order to remain relevant to the poor who we desire to serve. The stretch on our ethical compasses in doing this can be extremely challenging, and it is really a humbling journey. The particular challenges highlighted by the pandemic include hunger, loss of livelihoods, lockdowns that made access to healthcare difficult, and resulted in many para-COVID deaths during the pandemic for other illnesses that could not be treated. The overwhelmed healthcare system, supplies of crucial drugs often being cut off, including a difficult 4-week period where we had no morphine for our patients. In the light of the local travel restrictions during the pandemic, we were able to get special permission from district authorities for our ambulance to travel to villages so that we could continue our home-based palliative care services. As our team traveled to the homes of patients during the first wave of the pandemic, they saw firsthand the devastation caused by the effects of the pandemic. Migrant workers returned home to their villages by the hundreds on foot, many of them forced to live out their 2-week quarantine period outside their villages in the fields because the villagers in the village were afraid that they would bring the virus in with them. Hungry families with gaunt faces, exhausted from their long journeys, were everywhere. Food rations were provided for about 700 vulnerable families for a period of 5 months, and this support continues for very vulnerable families even now. This support was distributed by our palliative care team, who through their pre-existing networks with village heads and local people of influence were able to administer this support on the ground efficiently, justly, and transparently. One of the village headmen said of the palliative care team, "You are like angels of hope, bringing food, love, comfort, and hope to our people in their time of need." Over the 4 years that the palliative care service at Chinchpada has existed, the team has invested deeply in relationships in the community, growing in concentric circles around the patient with palliative care needs, who is placed at the center. Through regular sensitization and awareness among the various stakeholders in the community, palliative care, which was previously unheard of in this region and out of reach for most people, is now a frequently used term with many referrals to the team from the community. The training of volunteers has made it possible to widen the reach of basic palliative care to distant areas, delivered hands-on by our volunteers, with remote technical support and encouragement from the team, and the assured supply of required medications, including morphine. During the COVID pandemic, these relationships of trust were a great asset. In a milieu of fear, misinformation, and confusion, messages regarding dealing with COVID-19 were received more willingly from the team, which actively conducted COVID awareness in the community. Despite the team being associated with the hospital which catered to COVID-19 patients, a majority of the people in the communities welcomed their visits and appreciated their willingness to continue to associate with them, providing much needed multidimensional care. The example of the palliative care team in responding to the needs around them gave courage to many other people of goodwill in the communities to join hands in their efforts. These friendships are crucial to moving us forward towards our goal of access to palliative care for all the people in our impoverished region. Although the hospital provided COVID care during the first wave, the numbers were relatively low, with a maximum of about 12 patients admitted at any given time among our available 50 beds, so that we were able to provide COVID as well as non-COVID services at the hospital. However, during the second wave, we were engulfed by a tsunami of patients in a matter of days. Oxygen pipelines were installed overnight through uncanny foresight, and fast disappearing oxygen concentrators were procured at lightning speed. Over 48 hours, every available corner of the hospital was occupied by a COVID patient on a bed or on anything to lie on, including benches and boxes. So that instead of our usual capacity of 50 beds, we now had 84 COVID patients admitted with us. Countless people arrived gasping at our gates and breathed their last even before we could attend to them. We treated about 740 moderate to critical patients with COVID-19, each of our 4 available ventilators being used to cycle between 2 or 3 patients, sometimes 2 ventilators, 2 patients being ventilated simultaneously on a single ventilator. With this unprecedented workload, our small staff team of 7 doctors and 18 nurses was overwhelmed. At this point, every available hand on campus was brought in to respond to this crisis in various ways. The palliative care team once again rose to this challenge and worked tirelessly in the wards with various tasks. These included monitoring and reporting blood sugars, checking and rechecking saturations after alterations in oxygen flow rates, carrying food and supplies from the isolation ward door to patients on their beds, feeding and toileting of patients who were too sick to care for themselves in the absence of relatives inside the isolation ward, facilitating communication between patients and their families over phones. Many of them didn't have their own phones or didn't know how to handle one. Encouraging counseling and supporting families who were struggling under the burden and grief. Palliative care was also provided to those who warranted this and where time permitted it, with a special focus on symptom relief, facilitating goodbyes, and providing support to grieving families. We lost about 80 patients over a period of 6 weeks to severe COVID. This image of one of our patients who was 29 years old and his young wife, Pravina, as she stood weeping by his bed, accompanied by the palliative care team, as she held his hand and thanked him for being a loving husband to her and a good father to her 2 small children. This image will remain in our memories for a long time. Pravina was later visited in the community and helped to set up a small shop as a livelihood initiative through which she now supports her family. Several other families who lost their breadwinners were helped likewise. As the second wave ebbed, the team returned to the community, participating with bereaved families in their grief and helping them to process their loss, while they facilitated practical support in all possible ways through connections within the community. core palliative care work was resumed, and we found that we had lost a much higher number of our palliative care patients during the second week than usual. Over the period of the pandemic, we also started a hospital-based palliative care arm to include those with palliative care needs who live too far away for regular home-based care. Through phone calls by assigned members of the team and hands-on care with home visits by local volunteers who were trained by us, we were able to include more people in this circle of intentional, multidimensional care. This initiative also provided opportunities for increasing numbers of the hospital staff being sensitized, trained, and empowered to provide the person-centered holistic care that is the hallmark of palliative care. When we looked at what most of our people were dying of, we realized that tuberculosis and sickle cell disease crises, along with alcohol-related liver failure, were among the top 3 killers. Over the past 2 years, over 55 of our 370 patients with tuberculosis have died. Additionally, children and adults with sickle cell disease experience episodes of excruciating pain requiring opioids and die prematurely. We expanded the scope of our engagement with the community through palliative care, taking the same unique person-centered approach of palliative care to focus on these 3 major illnesses that are causing death in our community, as well as community-based disability rehabilitation, which shares many of the principles of palliative care, especially for those who are among the most marginalized. This engagement capitalizes on the strengths of our strong community networks through palliative care that are already in existence, the beauty of the holistic person-centered approach, and the competencies of the hospital that are available in providing excellent care for these life-limiting diseases, including through partnerships with government programs. What we are able to do may seem like a drop in the ocean of need in these impoverished recesses of our country, but the opportunities for being a model of excellence in relevant care for those who suffer on the margins and for being a leavening, facilitating influence in affirming human dignity are vast. We feel it is really worthwhile and indeed an honor to be a part of the palliative care movement in rural India. Thank you.
Wow, thank you so much, Ashita. That was really moving and quite an incredible presentation. So we've got time for some questions now and some discussion. I'm sure there's lots we can ask and learn from. I'm just going back up to the top. I think Sylvia's been answering some of the questions as they've gone on, Chamath, I see you've got a question there. Do you want to unmute yourself and ask it rather than me? I'm reading it now. You can do that, and then.
That was actually not a question.
Comment. Right.
Yeah.
Do you have a question?
No, actually, they were informative themselves.
Yeah.
Maybe quite a bit of questions as well, but then not at the moment.
Right. Okay.
Yeah.
And there's a question from Jennifer about teleconsultations and Sylvia's comment that they weren't always that useful and sort of face to face, which I think Sylvia's actually written a short answer to. Have you got any other comments on that at all, or Jennifer, do you want to follow up with anything, or anyone else got any thoughts on that? I mean, obviously we do teleconsultations, all the time in a way in palliative care, even without COVID, but obviously COVID has put things onto another level because of the isolation and the difficulty in getting to people. I've not had a huge amount of experience of the sort of change to that.
Yeah, sorry, Ben, can I ask a question?
Oh, sorry. Yeah, I just wondered, Sylvia, have you got anything? I'll come on to your question, Jam, in a second. Sylvia, have you got any other comments to make on teleconsultations?
I think it sort of depends very much on the population that you're caring for, but it's very easy that the patient themselves gets lost in a virtual consultation. And it's this thing of, yes, we could all go virtual, but should we be exploring whether we can't continue face to face? And sometimes I think we don't fight hard enough for our face to face in person meetings.
Yeah.
I think it has to be a very careful balance of what we're doing, would be my comment.
Yeah. Okay. No, that's really helpful. It's easy to hide behind it, isn't it? Saying, oh well, we can't do it, therefore we'll have to do it this way, when it might not be.
And it feels kind of modern and new and great, but it does carry some limitations. And I think everybody is feeling that about working with Zoom now as well. Yeah. So I would not want it to be seen as an excuse for not doing consultations in the person in the future.
I'm sure we can have a long discussion about that. Maybe we'll do in a later meeting. Ping Chen, I know that you've got a number of questions that you've asked there. Do you want to unmute yourself and ask?
Yes, thanks. So we'll have some questions associated, but not directly to your presentation, because I'm wonder if you have any information showing the changing pattern of place of end of life care or place of death in Malaysia during the COVID. Yeah, because it seems that changed a lot in European countries. And the second question is about that you mentioned the donation to charities, that is a huge impact on the donation to charities in the UK. And I'm wondering what is the situation in Malaysia and how you manage that challenge. Yeah, thanks.
Thank you for the question. I think that the first one, I don't have national data. How it was reported was deaths from COVID, daily deaths from COVID, and the number of patients brought in dead with COVID, which could be as much as 10%. And in terms of patients without COVID and where they died, only for our service, more were dying at home. I don't have national data on that. It can be quite difficult to get that kind of data for us. In terms of donations and funding, I'm not sure if Ednin wants to comment on that one.
Ping Chen, I think that similar to many places, there's a significant economic effect of this pandemic, and that affects the philanthropic people and organizations that depend on donor communities. And we were also affected by it, but also in a sense that we also needed to move very quickly. So we also went into various online methods of trying to get donations. I think one of the key elements for us was the fact that we kept going. Most palliative care services were stopped. People did not feel safe to continue, whereas we made it a huge publicity campaign by getting our patients and families to say thank you for visiting us. So that was very, very visible on social media, that whilst other community services shut down, we were still going, and that brought up quite a significant amount of support for our organization. But certainly there was still an effect to us, but I think that it was less worse than it could have been.
Thank you, Anthony.
I think that's a very interesting point, Ednin. The sort of increased capital from actually the hospice being seen to be engaging and wanting to provide a good service. Actually, the community noticed that. And I think that was something that Ashita mentioned as well. I just wondered, Ashita, do you want to just expand on that, and maybe some other sort of examples of how the palliative care has actually impacted on the community and changed relationships with your hospital and the community?
Yeah, Dan. So I think for us, it's really the palliative care team is very important, because the only community engagement we have is through palliative care. And I think in a way we are blessed in that, because palliative care is a very relational sort of engagement, and that kind of an engagement, I think, builds a lot of trust. And so we find that if someone from the palliative care team were to advise the people in the community to come to the hospital for certain evaluation, they would trust them and come. Whereas it would be, the default would be to seek help with a traditional healer or with the indigenous treatments, which might delay the right diagnosis. Also, because of the relationships in the community through palliative care, we find that the credibility of the hospital goes up. And also we have a window, having the palliative care work gives us the context for where our patients come from. And so having that in view, we are able to, sort of reprioritize the way we treat people when they come to the hospital. Because sometimes when they come to the hospital, they sort of just, you don't really know where they're coming from. But when you go into the community and you look around and you see the context from which they come, it changes everything. And so I think this dynamic has been really crucial in the way that we have evolved our services to remain relevant to this area. And the other thing is that often the palliative care team is coming back to us with stories about the patients who are actually admitted in our communities, because they know more than we do from what we get of the history from the patient. So I think it's a really rich sort of give and take. And likewise, the palliative care team, when they go out into the community, go with a sense of confidence that there is a good hospital that can take care of people who do need to come to the hospital. And so I think it's a really great combination to have a community hospital and a palliative care team that is with a lot of integration, a lot of give and take and talk between the hospital and the palliative care team. So I think that having a palliative care service linked to the hospital has really enriched the way we practice even, say, critical care or emergency medicine or acute care. It's been transformed by the palliative care lens.
Oh, that's really interesting. And as you know, one of my pet areas of interest is actually how palliative care facilitates other things within universal health coverage, rather than just being a bolt-on to the rest of healthcare. And I think that's something which we really maybe as a group can explore in future meetings. I think that would be great. Jam, you had a question.
Oh yes, hi, Ashita. A very nice work that we can see in the North India. Yeah, just wondering, during this period, right? Are there any problems with availability of opioids like morphine in the hospital or in that region that you are serving?
Yes, for a period during the lockdowns, we did have challenges with access to morphine. So we had about a 4-week period where we really struggled without morphine. But apart from that, we've been blessed to have, after that it was restored and it's not been so bad. But I think one of the things is that being sort of away from any city, even without a pandemic, it's quite a challenge to have access to the resources that we need to be able to run the hospital. So I think we've sort of gotten used to innovating and used to doing without things and managing with what we've got. But yes.
I see. Okay. Have you heard about the CTC program that the APHN and the Lian Foundation has run in India? So there's actually a few hospitals in the northern side of India that are trained under us as well. I mean, during such time, we probably could also link up you with them and, you know, to share resources and things like that.
Sure, thank you. Thank you so much.
Yeah,
Okay.
you can send me an email if you're interested to like link up with the CTC group. Yeah.
Yeah,
Sure.
that's great. That's what this group is for, to link up, to link up across the region. So that's really good. I think we've got time maybe for one more question. If anyone has, please feel free to unmute yourself and ask.
Sorry, Dan, I made a comment. Could I ask something, please?
Yes, certainly.
Scott, yes, I was struck by Ashita when she mentioned about redefining quality. Yeah, and I was wondering if you'd say a little more about that, maybe even redefining it over time. Did it relate to the first and the second phase? And I think you started to explain that answering the last question, because you're maybe using a palliative care lens to define quality, having that understanding rather than using death rate or something. But something more about how you redefine quality over time would be really interesting.
Yeah. I think, Scott, when we talk about, quality, sometimes what we refer to are predefined standards that are set by a certain body that has the authority, saying this is what high quality care for this particular condition would look like, and these are the protocols, and this is what you must do to get good outcomes.
Yes.
But I've often, found that when we match those standards to the real world of our patients, most of our patients will not be able to receive that standard of care for various reasons, because we are remote, we don't have access to it. For example, if I have to get an ultrasound for a patient, we still need to send our patient 60 kilometers away. If I have to get an imaging for a CT scan or an MRI, they have to go 150 kilometers away. And standards say for an unconscious patient would demand that they have a screening CT scan to ensure that there's no IC bleed or a space occupying lesion. But I would rather look at the patient and make a clinical diagnosis and take a few risks after doing a fundus examination and do a lumbar puncture without a CT scan. Because were I to tell my patient that you need a CT scan, they will just take the patient home to die and lose that window of opportunity for treating probably TB meningitis or a pneumococcal meningitis and sickle cell disease. And there are risks involved, I agree. But then in a relationship where we have open communication with the patients and keep on explaining that we have their best interests at heart, and these are our limitations and these are our options, it gives them space to say what they can and can't do. But if I were to stick strictly to the protocol of what quality demands, then I will lose so many patients. And so that redefinition is really at two levels. One is for the whole community, knowing what life is in general for most people here. And so we've changed our entire protocols to fit that and to be able to get most of them across, from dying to living. And then at the individual level, prioritizing depending on their clinical syndrome and thinking really hard and really specifically together about that particular patient, their context, their family, their illness, what are the likely outcomes. And so similarly, like for a say population of about 500,000 people, we are the only small ICU intensive care unit. And often we are, we're having to make decisions about whether to intubate and ventilate a patient. And those are hard decisions. And our patients usually don't have the, point of reference to understand many things. And we often have to to help them to make reasonable decisions. And so I think just matching the context with what is prescribed standard is something that we just, struggle with and learn to do better every day.
Yeah, thanks so much. It's interesting. I mean, you showed a picture of half a radiator, and this is not normally defined as quality care, but being explicit about resources and the lady holding her husband's, the dying husband there, just giving that spiritual support and comfort, which was not allowed in some other health systems like care homes in the UK. It's really quite touching on that. Mm-hmm. So thank you for that. And I'm sure it is this palliative care lens bit that you're not just looking at the illness, although you are looking at specific illnesses, sickle cell and TB, but you're actually looking at all the 4 dimensions and thinking about the future, the whole person. Thank you. That's very interesting.
That was great, and thanks, Scott, for the question. One last question for Maria in Indonesia about to Sylvia about collaborating with government primary health centres in providing home care. Have you got a comment on that?
Yeah, so most of the community palliative care is done by NGOs in urban areas. There's a program from the hospitals to develop domiciliary palliative care, but that's a very it's in its infancy, and the two don't really talk to each other well enough in Malaysia. Where we are working is more with our academic family medicine colleagues. In terms, we've been involved in some research around COPD. We're hoping to do the same with renal care, and looking at it from a community aspect. And there's a research project looking at palliative care needs in a rural area. But in terms of supporting it's unclear whether family medicine really sees palliative care as something that they do. They tend to be chronic disease focused and not so person focused. And it's really quite unclear what happens to palliative care patients in the community. Most of them end up having to go to hospital because that's where the medication is and the expertise is. So we're not an ideal situation at all, I think, and that's something that needs to be worked on.
Okay, thanks very much, Sylvia, for that, and thanks to both you and Ashita for absolutely brilliant talks. I think we've all learnt so much. I'm sure that if other people have got questions, you'll be happy to get emails to ask those questions. And so I think we should give them a clap. I know we're muted, but we can all. So thanks very much. Thanks very much for that. And so we're going to go over to Ednin now to talk to us about how we can be linked in with the APHN and what that means for us individually and as a group. And yeah, so over to Ednin. Thank you, Ednin.
Hi, thanks, Dan. I prepared a couple of slides here because I think that hopefully it will help to gather people's minds a little bit. This group has been in existence for some time now, at least for the last 6 months or so. We've had a couple of meetings, and certainly one of the discussions that was whether this should be part of the APHN. The APHN Council a couple of months ago decided that they would allow the setting up of a primary palliative care special interest group. As you all know, to bring people with like-minded visions for delivery of palliative care to community within primary care to come together within a setting that hopefully will enhance cooperation, collaboration, communication. Some of you who have been part of this group will have seen the various objectives that we are wanting to develop as a group. And I certainly feel this is these are noble ideas and aims. And I do feel that being part of APHN actually gives a foundation to build these things on. The membership of the SIG is open to anyone really wanting to be part of it. Mainly, I guess it'll be healthcare workers, primary care doctors or palliative care workers who are interested in this area, either to collaborate, to do research, to be part of a networking sort of group, sharing ideas, learning from each other, developing resources. I think there are many things that can happen. What does it mean in relation to APHN? I honestly think it gives the group immediate existence within the APHN environment, and therefore it gives you immediate visibility to other palliative care supporters within the Asia Pacific region and other groups within APHN. We've got other special interest groups, and I think that having a host organization allows the ease of working together much easier. I think we were a bit of a nomadic group before, and now we've got Giam Tanan as the APHN Secretariat that really can organize these meetings, and there are many ways of putting information together, and I think it allows for potential growth within a recognized regional structure. As an example, I just wanted to share some of the development within the pediatric palliative care special interest group, which has been around for some time. So, you know, there is a section on the pediatric palliative care within our website. You see the key people running the group from many countries. They have a service directory, and they have been doing quite a few similar discussion webinars, just a bit like us, but going on for some time now. So they've got blogs and the webinars are all stored. People can look into it. And I think this really brings it together. They are running educational programs. They are part of the APHN conference. So, you know, today was the first time that APHN is hosting it, and it went onto our Facebook. So hopefully some of you may have joined in because this has been publicized within the APHN social media aspect. But really, I think that what is needed is really interest, action, and commitment by the people that are part of this group. I do feel a steering committee is needed, hopefully from various sectors representing the region, and for everyone else to suggest ideas, volunteering aspects of work that you think you might want to be involved with. And I think it could go quite far. Potential activities. We've been so used to webinars, as travel is still not really normal yet. I think we're cutting back again. But you know, the webinars that we've been having, maybe we could look into other aspects that might be worth sharing. Workshops, online workshops, online teaching, certified courses that are being done in different countries. Could we learn from that so that other countries could do similar aspects? Could we look at a regional development of postgraduate courses that are open across people in different regions? Developmental work, national, regional guidelines. We've got an active APHN research group now. Some elements of research, I think, could be very, very rewarding into the primary care area. And we are targeting a face-to-face physical conference in Incheon, Korea in a couple of years. And I think that might be really a wonderful idea to try and showcase developments in primary palliative care in 2 years' time in Korea. So I guess that's really what I wanted to share. And hopefully, you know, I would really like some ideas as to who might want to be part of this team going forwards. Volunteers are really very, very welcome. So that's all I have to say. So hope we've got some enthusiastic people wanting to lead. For me, as chair of APHN, I'm very happy to support any initiatives that I feel really that we could help out with.
Thank
Thanks,
you,
Dan.
Ed. That's really helpful. And I think I'm right in saying that if we carry on running these webinars as we plan to do once a quarter for now, I think anybody can join the webinar. It's not exclusively just for people who are members of APHN, but I think if you really do want to support the group, I would really encourage you to join APHN so that they get the support from us, that they need to continue with the secretariat and being able to help us and keeping the website going. So I think and I think their membership fees are very reasonable, and I think they've got a special deal on at the moment for is it 5 years for 4 or something.
Just to butt in briefly, Ashita, I think that your presentation was remarkable. Would you want to write it up so we could feature it into our eHospice edition?
Thank you so much, Ednan. Sure.
Yeah.
Thank you.
Yeah, that's great. So I would encourage you to remain engaged and to engage with the APHN if you're not already. I know that a lot of you are. But please do. The steering group, we have, I think, 4 people who are interested from different countries, and it would be good to have some others. I think there are so many countries in the Asia Pacific region that actually maybe having somebody from every country all at the same time would make it into quite a big group. So we're not planning to have a country representative, but I think having people from different countries is very good. So if you could, if you'd like to volunteer before you have your arm twisted, that would be excellent. And the names I've got, I'll be in touch with you in the next sort of week, or maybe early in the new year. Actually, it's Christmas, and that together we'll organise the next meeting and the next date, and then hopefully we can actually become a little bit better organised with the help of the secretariat to have a sort of, to be able to publicise our dates maybe for 2022. And so, any questions for Ednan or for anyone else about running of the group?
Could I just make a comment, Dan, that it would be great if people would step forward and be willing to be in the organising committee. I think everyone can be members of the group, as far as I can understand, and if we're joining that, and it's great. And just my experience in Europe and of having such a similar group has been very positive, and many people have enjoyed that, and it's been a great time together. And knowing some of you, I think it's a great possibility. So I just encourage this group to go forward. Also in Africa, there's been a similar wide group where we focus more on research and primary palliative care. But there are many aspects, I think, and I would see this as a great opportunity. And so I would encourage those who would like to step up onto some on the steering for a year or 2 or 3, and then moving off. Doesn't need to be all old experienced people, maybe a mixture of types of people would be helpful as well. So I'm here today just to encourage the launching of this group.
Okay, no, thank you.
And some of us could support in any way as you go forward to things. You can call up other people, but we are not part of the main, if you want to, the committee, the organising people. But there will be resources to call on.
Yeah.
Thanks.
That's great, and I think linking in with the other networks around the world over time, I think would be good as well to share our experiences and learn from each other.
And other resources that are just some thinking of resources that you could immediately grab. There are a number of things so you could start up from the other places, whether it's toolkits for doing things, or whether it's lectures that various people have done at different times. I could see it's quite a useful. You could have lectures to even given your individual countries about how to encourage primary palliative care there. So there's an economy of people advocating it to work together. Thanks.
Jam has put the link for the joining as a member of the APHN, so that would be great if it's in the chat. The email is very easy. It's secretariat@aphn.org. You might have noticed my email yesterday. If you haven't signed your consent form to say you're happy to have information shared with you and to be on the WhatsApp group, if that's what you want, you'll have to email secretariat@aphn.org to say you want to continue to receive information about these meetings. We're going to discontinue the very informal number of email addresses that we had before, mainly just to make sure that we comply with data protection regulations. So please don't lose touch with us by not making yourself known. I think most people on the call actually have filled in the form anyway, so that's fine. But do encourage other people and always invite other people to join meetings. When you know they're on. I think the more the merrier at these meetings. So anyway, if there's no other comments or questions, just like to say that we'll try and meet again in 3 months' time. So that will be March, and we'll send information about that out nearer the time. Well, we'll send a date out hopefully relatively soon. And so anyway, thank you so much to everyone. Thank you to the presenters, and wish you all a Merry Christmas and a Happy New Year, and hope that 2022 is maybe less fraught than 2021 has been for many of us. So take care, everybody, and